everyone, and thank you for joining us today. We know that this is a particularly trying time given the current ongoing pandemic and a lot of other issues, both locally and internationally. And so we appreciate you for joining us. And today our speaker is no other than Dr. Maria Guerda Nicolas, who is a professor in the School of Education and Human Development. Dr. Nicolas is a multicultural Haitian American and multilingual psychologist. She speaks Spanish, French, and Haitian Creole. Her research is reflective of her background and interests. Her research projects focus on developing culturally effective mental health interventions for people of color, with a particular focus on immigrant children, adolescents, and families. In addition, she conducts research on social support networks of Caribbean population with a specific focus on Haitians, spirituality in adolescents, and social support and mental health of Black individuals. She has published numerous books, been the leader of numerous projects, and really is an active voice, scholar, and prominent figure when we think about mental health in the Black community, and especially locally here in Miami and for the Haitian diaspora. So thank you so much, Dr. Nicolas. We're so happy that you're the one that's here to kick off the first of many seminars to come that's hosted by the Mental Health Disparities Corps. Thank you.
Thank you. Thank you so much, Dr. Dale. Thank you for the CHARM team for the invitation to be with all of you today. Super excited to kick off this series. Huge fan of CHARM and the work that's happening here with all of you. So, and if anybody know Dr. Dale, it's hard to say no to Dr. Dale. So even though we are 2 weeks away from the start of the semester where we're like craziness happening, but the opportunity to come in and be a part of this series is just simply one that I could not pass on. So I want to say thank you so much for the invitation. Special welcome to all of some of our students who are here from our program. Special welcome to some of our members of our school as well, School of Education and Human Development that are also here. Very much looking forward to the conversation that we're going to have today. No better time now and then for us to talk about the importance of integrating and ensuring that the interventions that we are providing to individuals are culturally grounded. And so what I'm hoping to do today is we're going to have like a storytelling, right? So I'm Haitian, so I come from a storytelling tradition. So think of this as sort of like you being taken for a ride for a story that I want to share with you a little bit about, the work that we've been doing for the last close to 30 years now and where we are, where we landed. Hopefully you'll get a chance to learn some lessons learned from us in terms of that process. So definitely, I'm going to go quickly, so don't mind me, that you just to allow yourself the opportunity to ask some questions. Those of you who are here or on Facebook, want to really situate what I'm about to say in terms of the social context, define some things clearly so we understand what we're talking about when we're talking about cultural issues. Talk a little bit about the intervention that we set out to implement, ways that we culturally adapted, the model that we used to culturally adapt it. Want to talk a little bit about some of the lessons learned and then leave some time and room for us to have a conversation about some of the things that we are sharing today. So I as a part of my training, I was trained as a cognitive behavioral psychologist, went and got some training in family systems work with Salvador Minuchin. And it is to that work, I think that all of my mentors thought that was going to be the next interventionist, like worldwide. So that it was their hope and their dream that they were training an interventionist who was going to be able to really bring a level of fame to the interventionist community as well. So part of the reasons for why my career kicked out like that is because that is in fact what I sought out to do, specifically in terms of the work. So let's talk a little bit about the social context and why this work was important to me and why it probably is important to many of you. We know very well that we are living in a society that's really layered in terms of identities, right? And so we cannot continue to think of people as a monolingual, cultural folks, because we are both seeing individuals that speaks more than one languages. So Miami is such a good example of that I can absolutely meet somebody who looks Chinese, but they speak Jamaican patois, right? So that kind of like understanding that the environment, the social context in terms of the language is really is important. We certainly know that we're having more seniors who are part of the workforce than before. So that's a part of our culture, right? The context. We certainly know that in terms of our ethnic and racial population, we're seeing an increased rate of that, an increased rate of immigration, and of course, our LGBTQ population, which is really is important. So in a nutshell, I think this slide is saying we can't afford to not do this, right? That we can't afford to just take interventions and just assume that they're going to work for everyone without really taking into account the people for whom these interventions were created and to what extent are these interventions appropriate right now. So very quickly, because we're talking about cultural adaptation, right? Let's talk a little bit about what do we mean by that. So this slide speaks a little bit about what do we mean by culture and what do we mean about issues of competency, right? Because that's ultimately what we're trying to get at is how do we ensure that all of us have a level of competence, and I put that in quote because I don't believe we ever become competent. So I don't want anybody to get it twisted that we're actually gonna be in a process where we're actually gonna be fully competent and we're done. You know, as somebody who teaches this stuff, works around this stuff, we still need to make sure that that I'm still pushing and learning, right? Because it's an ongoing process, right? So so it really is important to be clear about what we're talking about when we talk about cultural areas and when we're talking about competency. So quickly, so we're really talking about from a cultural standpoint, all of the elements, and there are so many elements when it comes to like cultural stuff that is really is important to keep in mind, whether or not it's somebody's racial, ethnic, religious, or their social group, their SES, you know, the customs, the beliefs, all of that falls into this concept of culture that we're talking about. When we think about cultural competency, it's oftentimes these are the areas that we pay attention to in terms of cultural knowledge, cultural awareness, and cultural sensitivity. And we've seen when we're thinking about issues about diversity and multiculturalism, that it is important that we are spending some time to increase our knowledge about certain things. That means we are familiarizing ourselves. We are getting out of our comfort zone, right? In terms of enhancing our knowledge. We are becoming much more aware of ways that cultural values, cultural beliefs, and all of that impacts one's behavior, you know, and so forth. And then cultural sensitivity is about understanding the differences that exist between various groups, right? So that we don't necessarily look at things as right or wrong, but that we're able to understand and have a level of understanding, right, to some of those sort of nuances, the cultural nuances and so forth. So it's good to keep those terms in mind as we go through this presentation today. I want to share with you, because it would be too big to kind of like talk about cultural adaptation of mental health interventions in a global way. So I wanted to situate it around children and adolescents because it as an opportunity for you to kind of like use that as an example for what this means. And in part because that's how my career and my work began, to really look at the issue about mental health and mental health for children and adolescents, particularly Black adolescents was my focus. So for that, it was important to understand what do we know about mental health statuses of children and adolescents. So this slide tells you in a nutshell that the children needed us, that there was lots of research to show that kids were dealing with a number of different mental health problems, that venturing into an area of looking at mental health for children was an important one, because the research was clear that our children and our adolescents are dealing with a number of issues from trauma to anxiety to depression that really warrant us to pay attention to all of that, right, as well. The other thing that we wanted to pay attention to is when you look at like the impact that treatment would have had overall on children and adolescents. So we also looked at that as well. So what are some of the ways that treatment seems to be impacting the overall experiences of all adolescents? Again, not just the Black adolescents that I was interested in, but all adolescents in terms of the work. And so one of the things we saw, and these are just like example of what young people are saying. So look at each group of these quotes as you're looking at it. So you're talking about 9-year-old, 8-year-old talking about their experiences with anxiety, with depression, right? And so forth and so on. So we knew that in fact, we were in the right place because our young people were dealing with a number of challenges and difficulties in terms of their life experiences overall. So we take all of that and then we say, well, what does that look like for children of color? So now that we know what it looks like for children in general, but is it the same thing when we look at children of color, right? And when we look at the data, it is also clear that our kids of color, our Black and brown kids, Asian kids, also were experiencing a number of mental health challenges as well, right? So whether or not it's suicide issues or depression issues or anxiety issues, that name it, they were also experiencing it. So point number two, we were like, yes, mental health of children was important. Number two, the mental health of Black and kids of color was also important, that it was an area that really needed our attention. And then lastly, of course, which all of you know, which is what CHARM is all about, is about addressing the disparities that exist. So we didn't have to prove any of that because we know very well that there exist significant disparities when it comes to mental health of people of color in this society, and notwithstanding children being a significant part of that as well, right? So lastly, we also look to see, well, that's all great, but are these kids able to get services? So if they're able to get services, I may not necessarily need to do anything about that if they're in fact accessing services in a really effective way. Well, guess what? Point number four, they also had a number of barriers to getting service, to receiving mental health services. And some of that was culturally, right? Some of it was about the availability of services. Some of it was related to the healthcare system in general. And some of it was related to cultural mistrust and of the system and of individuals being able to provide that care, right? And some of it was related to the fact that the treatment that they received before was not inadequate, right? And that's really important for us in the mental health field because we know very well that people of color don't go to myself as a psychologist as a first go around for mental health services. So if we are providing inadequate care when they finally get to us, then we are the last resort, then we're really in trouble, right? In terms of making sure that people are getting good care. So all good, all right. So that's clear. I'm on the right path. I'm going on the right mountain. You know, like this process is needed in terms of being able to do that kind of work. So I honed it on a little bit and I said, let me take a look at just depression. So now that we know that in general, that adolescents of color needs help, they need our services, and there's a number of issues with that. I wanted to see specifically, can I really pick something like depression to begin to really make some headway vis-a-vis mental health services and so forth. So when I look at the depression component, right? So it's clear that depression was one of the most prevalent issues that our adolescents and young people were also dealing with as well. So good there. Importantly, it looks like when I look at all of that treatment for adolescents' depression, very few of those studies actually included ethnic minority populations as a part of this study. So there were studies, there were interventions on adolescents and depression, but very few of them really focused on ethnically minority adolescents. So far, so good. I'm still on the right path. So now I set out to do a study to really begin to develop a culturally effective intervention for Black adolescents, right, who are specifically depressed, right? So very, very specific. So very focused on this study. I'm trying to see about the feasibility of culturally adapting this intervention that has been used for adolescents throughout the country, that was developed by Gregory Clark of those folks out of Oregon. I want to see, like, to what extent can the kids engage in the treatment once it's been adapted? Does that matter for the most part? And then lastly, are they able to tolerate the intervention by really documenting and monitoring the decrease of their symptoms post the treatment and follow-up? So far, I'm really golden. I have an excellent care award. I'm on my way. I'm about to really develop culturally effective intervention for Black adolescents. This is the first go at it, and this is gonna be fantastic. So I'm on, okay, you guys, I'm on, the train is going. I have an excellent model that I'm using. The cognitive behavior therapy model is my framework because that's what I was trained in, and it makes sense for us. And then I have an intervention. So the Adolescent Coping with Depression course, you guys can look it up. It's an 8 weeks intervention program. It's about 2 hours long. It's about 16 sessions over an 8-week period. And that intervention was like blowing up like nationwide because it was having such successes that kids who participated in this intervention program would come in and their scores on the depression measures would be really high. By the end of the treatment, it would be like, I'm talking so low. And then like follow-up, 3 to 6 months follow-up, it would be even lower, right? I was like, golden intervention. That's the one I'm gonna use to culturally adapt it for Black adolescents who are depressed because it's had such level of efficacy, right? And so forth and so on. So this tells you a little bit about that. This shows you a little bit about the intervention itself. You know, I am like, you know, top researcher. As you can see, I have like my lovely, like the table's all set. My intervention is ready. I'm good to go. Like, right, the how I'm going to implement this intervention the same way, you know, to really adapt it. I'm golden right about now. And then I have a very good mentor of mine, which is Dr. Guillermo Bonal at that time, who had also created a model for culturally adapting interventions for people of color that was like blowing up as well. So that was his area. A lot of people were using it with Latino folks. They were using it with Asians, but not a whole lot of people had used it yet with Black adolescents. So I was like, yes, Guerda is going to be the first one. I'm going to use this model, which is perfect to use because I'm able to take the intervention and I take a group of Black adolescents and they go through the intervention with me, sessions by session, word by word, and we do it based on these elements, right? So this is an excellent model because the elements are, you're looking at the language that is used in the intervention, you're looking at the metaphors that are you using, you look at the content of the intervention, the concepts that are used, like for example, the concept of depression, which is a concept, is that what people use across? Does that make sense to people? We look at the goals of the intervention, the methods, the context, and then the person itself, right? Awesome model to use. And we used it and we culturally adapt the intervention. I'm not gonna bore you with all of the ways that it worked. What was really clear to us in terms of using this model is that with working with the adolescents, it was clear that we did need to adapt the intervention. So that's like your quick take-home message. So even though the Adolescent Coping with Depression course had been used nationwide, had really wonderful effectiveness, was very efficacious to use with adolescents with depression, it turns out we did need to culturally adapt it for the purpose of being used with Black adolescents. A lot of things changes from like the metaphors that were used to the examples that were used to make sure that they were much more culturally in alignment. So we spent about 1.5 years culturally adapting this intervention to really implement it, and then, you know, which was really fantastic. I had excellent settings, right? Because I'm now at either UM, we can use it in a variety of different settings. So because now we have our cultural adaptation measure, and we have settings to be able to do that work, which is really exciting. We have an excellent sample. We have good eligibility, good exclusion criteria. Like we are good researchers following good guidelines for implementing interventions, right? So we are ready to go. We have our culturally adaptive intervention, right? And so forth. So we implement the intervention. We're ready to do our analysis and we set our aim, right? Really clearly of how we're gonna, you know, assess the interventions and so forth. So here's where things really go sour for me, okay? So far, Aren't you excited? Like everything seemed to be really working well. And you're like, we have an intervention, we have a population, we know the issues, we have a good model to adapt it, we adapted the intervention, we have our analysis set to be able to run and so forth. And then we run the analysis on the study, and you know, and what we found was the kids who showed up in the intervention, their scores post the intervention didn't change. Okay, I know you guys are feeling me right about now, right? So remember, we just spent 2 years, you know, we have a good model, we adapted the intervention, and everything is going really well. We implement the intervention, we give them the post measure, and then post measure scores on the Beck depression, which we use, the CSD depression measure, which we use, didn't change. Okay, the end of presentation. Okay, not the end of the presentation. Okay, so what happened, right? So then we were like completely perplexed. Like what happened to this study? So one of the things we learned is that while we were so busy making sure that we culturally adapt the intervention, we failed to actually think about to what extent were the symptoms of depression on the measures that we were using were culturally appropriate for the population of which that we were using this amazing culturally adaptive interventions for. Are you following? So, which is very common, right? That people culturally adapt interventions, they implement them, and then we forget about the outcome measures that we are using, and to what extent are those measures culturally appropriate to be used. So here's the thing about depression. We know that depression is in fact cultural, that culture significantly influences the manifestation and the shaping of depression symptoms, right? And our colleagues, Kleiman and Good, put an excellent book on depression and culture, has a little green cover. If you don't know it, please pick it up, which was amazing. That was there to tell us that in fact, the way that we were thinking about depression really needed to take into account all of those cultural terms that I shared with you at the beginning in terms of our cultural knowledge, cultural sensitivity, and cultural awareness and so forth. Here's the thing about that we learn about depression is that the terminologies that we use across the globe to refer to depression also matters. So it turns out that the word depression is actually one that is very common among English-speaking folks. Like other folks don't actually use that word. So if you actually go across the globe and you say, I'm going to give a question, other people may not know what you're actually saying. For us, for example, in my own cultural processes, we don't have a word for depression. The closest we can get to the word depression in Creole is to say the English word with a Creole sound. So we're going to say depression, but nobody understands what that means. I'm just using an English word with a Creole accent, you see? So, and if you look to see how people are saying the word across the globe, it also matters. So imagine if you go to Korea and you're talking about depression and how it affects the mind, and in Korea, the word for it is a sinking heart. You get it? Like, how is that? How would that make sense globally? Okay, let me keep going because I'm going to run out of time in a minute. So one of the things that we learned about depression, for example, for Haitians, to the research that we did, is that there are these different types of depressions among Haitians. And so we can't use the DSM or the DISC or the SKID, whatever else your diagnostic tools are being used, Dr. Dell and the team. We can't just use those diagnostic tools to actually assess somebody's like psychopathology, because psychosis and psychopathology, mental health issues look differently for people of color. And I don't think that DSM has caught on yet around ways that these symptoms are manifest itself around different cultural groups. So one of the things we learned about Haitians was the case, that there was these different types of depression, which was good news because it allowed us to know that we really needed to rethink things a little bit. So The second thing that was really is important is to really think about the assessment piece. Remember what I just said is that the assessment instrument that we were using, we sought out to culturally adapt interventions. But in order for us to show that the interventions work, we have to use outcome measures. We have to use assessment instruments and outcome measures to document whether or not this intervention is working or not, right? So guess what? We spent a whole lot of time culturally adapting interventions, not a whole lot of time culturally adapting the assessment instruments that we are using. So I want to, move through this, again, really trying to make sure that I leave some time to really, so you can ask some questions at all as well, to go to a process with you of this, what we had to do about culturally adapting instruments, right? And so this is a process that we went through to really take a look at both the CSD and the Beck Depression Inventory. And I won't bore you with all of that, but one of the things that we learned through this process is, and I don't know if any of you have had an opportunity to really take a look at the items of the measures, because we sometimes as researchers, we do a good search to our PsycInfo, Medline, PubMed, all of that. And if the measures seem to have good psychometric properties, and by good psychometric properties for us, it means it's very reliable. We're like, good measure. So Dr. Dell sent some people to say, let's find some good measures that we can use for Black folks or Haitian folks in Miami. And they find those measures and it has good reliability. The coefficient is really, really high. Then we say, let's use that. But just because it's reliable doesn't mean it's valid, right? So validity and reliability are not the same thing, which we know, but we tend to give a whole lot of credit to reliability than we do to validity, right? So what does that mean? It means that if Dr. Dell asked me, what color is the sky? And I said, it's purple today, on Wednesday. And she asked me that question again tomorrow, and I said, it's purple. And she asked me that question again on Friday, and I said, it's purple. Guess what I have? I have excellent reliability. Is the sky purple? No. You know what I'm saying? It's not purple, right? And that's the difference between validity and the reliability part. So we give a lot of credit to reliability, but not a whole lot of credit to validity. So for us to really get at the validity piece, we have to take a look at the items of those measures. So when we give, like as an example, when we begin to do the cultural adaptation of those measures, with particularly with Black folks and particularly with Black folks in Miami, and we were giving them these measures. We gave the Beck Depression and we gave, the CSD. Man, I'm gonna tell you in a minute what they said, but here's what we know about the CSD measure as an example. If you look at the item of the CSD, there are items in there that for the most part, older Black folks, particularly older African-American folks, tend to always be high on those items. It doesn't make a difference whether or not the depression is low, but they're gonna be high on some of those items. And here are some of those items here. People were unfriendly, right? I felt that people disliked me. Well, it turns out that is completely linked to the fact that you grew up in a racist society, an enslaved society, in a society where you are being dehumanized, in terms of your experiences. So when you see that item, if I found that item right now in the middle of Black Lives Matter that people were unfriendly to me, the answer would be like 5 all the time, right? But it doesn't necessarily mean it's linked to my depression. It is linked directly to my experiences as a Black person in the United States of America, right? So some of those items and those measures may be tapping into something else other than the thing I'm trying to measure, which is depression, right? So we sought out to do that. The other thing I wanted to say very quickly related to that was the BDI. And my colleagues over at the Beck Depression Institute, they think I have a thing with the BDI. I'm not really after to get to the BDI, but we really need to take a look at the BDI because the BDI has been translated in every single language there is globally. But that doesn't necessarily mean the items are absolutely valid for everybody across the globe. And we need to pay attention to that significantly. When we give the BDI to our folks to take a look at, the item that got the most, when I said the most, you know, when you do a focus group of Black folks and you're asking them to give you their opinion using a structure to tell you about what are some of the things that they have issues with, I'm telling you, we spent 25, 30 minutes or more on the word blue, because there's an item on the bed depression that says, I feel blue. And people were like, what kind of blue do they mean? Is it ocean blue? Is it sky blue? Is it like indigo blue? Is it this blue? Is it like the word blue didn't mean anything for the folks that we were meeting with? That means, so that word, which is so important for me to answer this question, so crucial, the word blue, I can't answer the question because I'm so busy trying to figure out what kind of blue are you asking me to be? Because if I'm sky blue, that's very different than if I'm ocean blue or if I'm like indigo blue, right? And again, these are the kinds of items that are in a measure that's assessing my depression level, right? And I'm sitting there trying to figure out what does that mean? But we know very well that our folks don't spend the time to trying to figure out what that means. They just put an answer because they don't get it. And which is what happened during this process. They just circled a number. They didn't know what it meant, but they're like, I'm gonna put a 1. I'm gonna put a 2, right? Not necessarily because that meant anything to them, because they didn't understand what that was getting at to begin with. Okay. So out of that, we created a model for how to actually culturally adapt measures in a way that would make sense. So now we can have cultural adaptation of interventions and cultural adaptations of measures. So in my 10 minutes I have with you, because I'm going to leave some time for them to really want to hear your questions and stuff as well. I want to share with you this model. It's called the Casa Model. You know, mi casa, su casa. Yeah, that's the way we want to think of it. We call it the Casa Model, called the culturally authentic scaling approach, Casa Model. And the model calls for us to begin this work in community partnership, because the community partnership is important. I'm going to go through this very quickly. So it calls for community partnership, thinking about the theory that we are using, right? The theory that we use, that the measure was used to create the measure to begin with, okay? Think about the selection of the measure. What is the process for selecting the measure? How we administer that measure, which also need to be culturally appropriate, and then how do we feed that information back to the larger community as well. So in my very short period of time, I'm gonna go quickly. The community partnership is important because it means that you are starting that process by understanding and ingraining your work within the community in which you wanna be a part of. We're not doing work in community, in communities, we're doing work with communities. So we already have to be a part of the communities so that way we can understand some of the indigenous responses, the indigenous ways that we need to be able to do that work. We can't just get a grant and say, wouldn't that be great to go to X community and do this work? And we're just planting ourselves in a community to do the work. It will not be authentic. It will not be indigenous in nature. So this process that I've outlined for you here as the beginning, it is a step that cannot be skipped. You absolutely need to have that partnership in order for you to be able to have the buy-in, to have the trust in the community, so that people can absolutely tell you the truth of what is it that they're experiencing and how they're experiencing these things. So that's the first step. The next step is around the theoretical equivalency of the model. We really have to ask ourselves the question, is this measure I'm gonna use the theory that was used? So if we look at the CBT model, for example, that says it is my cognition that is affecting my behavior, which then affect all of, does that make sense for somebody in Korea who actually think that depression is related to the fact that the heart is sinking? Does the model itself, the theory that was used to create these measures, we need to interrogate them, we need to analyze them, we need to pull those up and say, are they relevant? We know very well the majority of the theories that we have in the field of psychology are all theories that were predominantly created by white men from a particular area for white populations, right? So those theories continue to be perpetuated, and to the extent that they're now a part of measures, we need to absolutely do the work vis-a-vis that. That gets at this piece around measure selection, which is the third part of this model, in terms of really paying attention to the language, the items, the scale that is being used, like the words that is in that it induces, issues of the Likert scale. My goodness, man, if you look at Cronbach Alpha, didn't expect us to use Cronbach Alpha the way we're using Cronbach Alpha. The Likert scale, nobody has ever questioned the Likert scale and say, like, how do you make a determination on a 1 to 5 scale? How do you make the distinction between a 3 and a 4? And what do you use to measure this piece of 4 versus a 1? We've never really interrogated that. And one of the things that we learned to our work is that the Likert scale meant nothing to people, nothing. So we had to change it as a part of our intervention. So we changed, not necessarily change the Likert scale, but we changed how we use a Likert. So for example, as an example, we actually use a cup as a Likert scale. So when we're asking somebody how much of something, we have a cup, and the cup has nothing. The cup has a little something, something. The cup has a little something, something, something. And then the cup has a little halfway through. And then the cup has a whole, and then the cup is full. So when we're saying to somebody, can you tell me how you are feeling right about now? It's easy for a person to say, oh, my cup is full, girl. It's full, or my cup is a. You see how they can make that distinction? Because you're giving them a scale that is relevant to how they're experiencing things overall, right? So really thinking about that is important. Let me just say this one word. Translating a measure from one language to another is not cultural adaptation. Let me just say again, just because you've translated a measure from one language to the other is not enough. That is not enough for cultural adaptation. You absolutely need to take a look at the scaling of that. You need to look at the items of that. And then you need to see to what extent is the scale that you are using eliciting the kind of responses that you really need in this society, right? So again, really thinking about measure selection, think about the sensitivity of the measure, think about the reliability of the measure, think about the validity of the items, think about the demographic factors and how those things could affect what you do. So one of the things that we do in our studies, not only do we ask people those racial boxes that the society wants people to fill out because NIH wants us to really ask those racial questions, but we also let people figure out, tell us who you are, how you identify as well. And Dr. Dale, we asked the researcher who's completing these things to also fill out their own demographic questionnaire to see how do they identify themselves, to see whether or not there's any congruency between the person who's asking the question and the person who's responding to those questions as well and so forth. Okay, I gotta go. Okay, I gotta go. Okay. So the other thing I want to mention about measure evaluation that I think it's important to think about the kind of cognitive and emotional things that measures are supposed to induce in general, right? So sometimes we're asking these depression measures, and I know I have a very good colleague of mine who's doing this work right now out of UCLA with Asians. And it's like, to what extent are we asking adolescents questions about their mood? That is our typical adolescent stuff, right? Like things like how I see myself, sleeping, eating. Are they truly just only depression stuff, or the typical adolescent stuff that we are using and measuring to a depression measure and so forth? This is what I'm talking about in terms of these things. The other piece that I want to mention, which I talked a little bit about the Likert scale already, but I want us to really pay attention to the way that we're doing our analysis as well of these measures, right? And so these other models of really taking a look at things like items response theory, you can really look to see how does Guerda absolutely respond to this measure against Guerda, right? So how am I responding to the items of this scale? So there are methods that we can use that are different than what is normally done. We need to stop just saying, just because everybody's done it, that doesn't mean it's good, people, okay? Just because, that's the norm. Let's get outside of that and actually begin to think of the things that is going to be good for the population that we want to do that work with and so forth. Lastly, I want to mention this piece around measure administration, which is the last part of that, which is how you actually collect the information, the ways that you collect the information, the rapport that you have with the information. We had an experience in Miami a number of years ago where we actually thought, we had this wonderful grant. We put it in the grant that we're getting this iPad, Dr. Dell. We're going to administer these measures in this particular way because it was going to be so easy. People can just fill out the thing on the iPad. Our team gets it immediately, and then we can begin to do something with it. And one of the things I noticed about doing the project that my team would go, we had a group of people show up, and then we have our iPad, and we give them the iPad to start doing it. They wouldn't do it. They're like, oh, I'm busy now. I forgot. I had to go pick up the kids. Oh, let me do it another time. So I had to sit down with them and say, well, what's going on? Like, if you schedule a time to come, that means you really wanted to do this thing. And you know what the issue was? The iPad. They're like, I don't know this thing. I don't know where it's going. I don't know who's going to see it. I don't know where my stuff is going. So even though we had explained this piece, it seems like the procedure, the administration was going to be so much easier for us, but it wasn't going to get us the valid data that we absolutely wanted from the participants. So really paying attention to this is really, 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 really important, right? As well. And so I have some examples in there in terms of what I mean by the measuring administration as we think about both sample equivalency as well as the neighborhood and organizational context. Like when we don't feel comfortable and we ask people to come to the University of Miami campus to fill out our measure because we don't want to go to Overtown, we don't want to go to Liberty City. That's what I'm talking about in terms of the administration of measures and to what extent people are going to feel comfortable with providing the items that we need and so forth. Lastly, let me say how important in terms of this Casa Model is, which is the community discourse. We have got to do the work of ensuring that the people who get the results of the things that we are doing go back to the community for whom that we care about and we want to do this work about. They have got to be the first go-to people that we go to tell about the kind of results that we're finding. It is not a PA presentation. It is not a publication. It is right back at the community to bring in the community leaders, bring in the trusted leaders, bring in the people who are really essential part of this, have community discourse with them on how they can integrate some of this stuff. That's what we mean about cultural adaptation of interventions, because it really is ingrained to the culture and overall. I think ultimately, I want to leave you with this, and that is, George Trumbull is an excellent colleague who's been doing work as a Native American researcher out of Washington State, amazing colleague, mentor to me for many, many decades. It is clear to me that that people in our community, if you show up and you ask them, because that is the nature of Black folks, people come to us and they ask for something, we will do it. That doesn't mean what I'm giving you is good. That doesn't mean what I'm giving you is a reflection of what I'm really experiencing. I'm just filling out the measure because you asked me to fill out this measure. So people will absolutely complete certain things. They will participate in it, but whether or not they are absolutely integrating and sharing with you and trusting you about their personal thing is important. So we have a responsibility. We have a responsibility as researchers. We have responsibility as individuals who cares about humanity, who cares about system change, to recognize that we have to. It is not a if, it is not about a when. It is something that we must change the process and the methods by how we are developing interventions to people of color in this country. If we don't do that, we're going to continue to talk about disparities. Another 50 years, Dr. Dale, there'll be another group of people in Charm talking about health disparities unless we have a way to ensure that we are doing it and we are doing it right. The time is now. We don't have any more excuses. Let's get to it. Thanks so much.
Thank you so much, Dr. Nicolas. That was amazing. I don't know if you saw the comments, but everyone loved your mastery of the content, your energy, everything. And we have some questions in the Q&A. The first one is asking, are there existing versions of assessments that have been culturally adapted or in the process of being adapted? So what would you recommend in terms of measures from a mental health standpoint?
Absolutely. The good news is that we have, over the last, I would say 15 years, we've had a number of colleagues working specifically on this piece around culturally adapting measures. Before, we spent a lot of time on culturally adapting the interventions itself, but not on the measures. So if you look at people like the Orozco, you look at people like Maggie Alegria, who's been doing it with Latinos. You look at what's my brother's name out of California, who's doing it with Asians there as well. So there's a number of right now of really excellent measures that have been properly culturally adapted. So we're not continuing to use the same measures again. But if in fact you want to culturally adapt a measure, I think that part of having this Casa model is to show you how you can do that, how you can devote the time to do so.
And if I was to ask a follow-up to that, Guerda, what about for students, trainees, people in practice for whom there are measures that are already there, like set up as a standard in the clinic or other settings that they're utilizing? What are some strategies they may use to make that more beneficial than not?
Absolutely, absolutely. I hear this quite a lot because the student says to me, but we don't have any power, we don't have a power in the system. We're just interns who are coming into the system. They've been using these measures all the time. And I said, you do, it is your responsibility. You don't get a pass. We're gonna have to all be woke about this. We're all gonna have to be like, you have to be able to say, I know better. I know better because you wanna do better by the people that you're serving. And sometimes the clinics haven't even thought about it. They've just been using the same measures because that's what's been there. Nobody has come in and said, hey, have you thought about using these measures instead? Let's bring in somebody who can help us take these measures and culturally adapt them. So your voice as a student, your voice as a trainee, because you are in the thick of it, you know better, is so important. And I want to empower people, everybody, right, to know that you can make a change, right? But it's not okay for you to notice it and close your eyes because this is not a parade. You're not getting a seat and sitting on the sideline and letting the parade go by. Right? You have to be a significant part of this.
Thank you. Thank you. Another question we have here is, what have been your observations, given everything that you said about the move to remote platforms or telehealth, especially in the context of COVID, and how people of color, Black individuals have been responding to that?
Yeah, that's been a really an interesting process for us. Even for us, we run a family program and an identity program for Black kids, and we had to do it also virtually. One of the things that we learned, Dr. Dell, is that there's a level of digital literacy that we hadn't even thought about. So this piece around digital disparities is real, right? That our folks haven't been schooled, haven't been oriented to this digital life and digital platform in any particular way. But what's so great is that when people feel that you care and you want their very best, and you are taking the time to meet with them, meet where they are at. We literally walk our people to how to get onto a Zoom, literally on the phone. So you're gonna get the link now. The link is gonna say you click it, and then you like that process. And once they get in, that kind of feeling when they get in, that can still come through even though you're on a Zoom. Because when folks who are culturally grounded come together, whether or not they're on a Zoom, on the phone, in person, you feel it. You can feel the energy there. So I think we can't just like let them show up on a Zoom, and those who didn't show up, we say, well, they didn't get in. Or when they show up on the Zoom, we just say, okay, let's get going, without doing the kind of warm up, the kind of exercises that we need to do. We hosted a session for a Jamaican project that we're doing on food with a good colleague of mine, Gail Ferguson, out of Minnesota. The session we hosted, we brought in a Jamaican DJ that was playing music at the beginning of the thing. So people came in and they were like jamming to like, you know, like to the Jamaican, and then we got started, right, in the Zoom. So people felt like, okay, this is really truly vibing. This is really truly culturally appropriate, right, in all of that. Those kinds of things are still possible, even though it's virtual.
There we go. Beautiful, Guerda. One more question we have here is that someone asks, is there a published model to use in order to adapt a questionnaire for a certain population? Like you mentioned the model that you share, but I gather they're asking for other models to help them walk through adaptation.
Yeah, absolutely. I mean, so Guillermo Bernal, and people should just look him up, Bernal. Guillermo Bernal has a whole team of people also out of Puerto Rico who's done a lot of work around adaptation of measures in addition to adaptation of interventions. So there are good models there. Remember my colleague's named Fred De Leon, right, who does a lot of work with Asians also. So that you just have to look these people up. The thing about doing culturally effective work is like, just doesn't happen. Like you just don't like show up on the computer and you're like, voila, there it is. Like, so you have to have a level of commitment and you have to do the digging. You have to read this person's article and then look at the references, read those articles, then read the references of those articles. Like you really are working so hard. But at the end, the benefit of doing so is so fantastic because you know what you are producing is culturally relevant to the population that you care about, that you want to do this work with. So absolutely keep on digging, I'll tell you, keep on looking for them. And I know that the School of Nursing, Vicky Matrani had, I know she's married now, it's not Matrani anymore, but she had at the El Centro, they have a link that has measures also that has been culturally adapted. I know they were collecting these measures also. That might be a great resources for people to actually access as well.
Yeah, the Clara Library. Awesome.
Yeah.
One last question. No one posted, but I'm curious to see your thoughts on this. But for individuals who want to do this work in terms of adaptation and working with community and, you know, BIPOC communities who may say, well, I struggle because I'm not from these communities, right? But this is an area of interest that I have and I want to do this work well. What will be some guiding principles that you would offer in terms of how they can go about doing this well and minimizing sort of like the positive impact and minimizing harm?
Yeah, absolutely. Here's the thing is that I tell people all the time, this is a commitment. We're making a life. This is not glasses you put on, you take off. This is not like an outfit you put on, you put off. We're talking about mind shifting, that you as a researcher, you as a clinician are saying that you are shifting your mind. That is a revolution with yourself. You are fighting with yourself to actually do it differently. And so because you are making a commitment, not to say, I'm doing this because Dr. Dale, I'm in her team, and she says we have to do it this way. See, that's a moment in time. But if you are saying you want to do this work, you have to say, I am making a commitment, a life change, and I'm changing my mental way of doing things. I'm shifting my mentality about things. And once you're doing that, it's not just about being a researcher. It's when you get to the grocery. It's when you go away on vacation. It's when you're at the gas station. It's everywhere you go that this is like such an essential part of yourself. So that way it doesn't become like something I'm doing as a researcher, but then when I remove my researcher hat on, then I'm somebody else, right? So you have to make a commitment that this is what I'm signing on to be. This is my train. This is who I am. This is what I do. This is how I do it. And because it's my commitment, my publication is going to be lower. The kind of places that I'm going to apply for the grants is going to be different because not all grantors wants to fund this kind of work, right? But you're not going to say, I'm discouraged. I'm going to stick off this ship and go somewhere else, right? So when I started out and I said I wanted to do this work with Haitians, people told me I was never going to be published because nobody cares about Haitians. nobody cares about Black adolescents, 12% of the population. You really needed to do it on adolescents of color. I said I cared about Black adolescents, right? And if I didn't get tenure, I'm gonna be good with that. I'm gonna take my PhD. I'm gonna go to McDonald's. I'm gonna be the best, French fry maker there is at McDonald's. But I was not going to shift simply because the system told me differently. So this is a marathon. It's not a sprint. You have to be committed to it and recognize along the way there's gonna be bumps, but stay with it. Because let me tell you, people know who I am now because of my work in the Haitian and the Black community. If I had given that up, I would have given me up. And I was not willing to give me up, because if I wasn't the one who's to do the work on Black adolescents and Haitian folks, who was gonna do that since there's so few of us? So stay committed to your passion, your interest in what you're doing, and don't let anything else derail you from that, because the outcome, the benefit, what you're gonna do at the end is unbelievable.
Yes, amen. Woo! Thank you, Dr. Nicolas. I don't see any more questions, but I just want to say thank you so much for launching us and being the first speaker of the seminars that are being hosted by the Mental Health Disparities Core of Charm. This was amazing. I see a lot of fabulous feedback in the chat. Please know that you could rewatch this via the Charm Facebook account, and we'll post it on the Charm website soon. But Dr. Nicolas, this has been amazing, just the insights, the energy, and the mastery, and we so appreciate you for doing this for us.
Thank you so much for the invitation. Thank you.